So therapeutic diet, how it is different from your nutritional supplements. Nutritional supplements is just one aspect of your diet. Okay. Therapeutic diet is the complete diet. Your morning, lunch, dinner, snacks. Okay. Everything is modified. Okay. Supplements you just have to add. You already have a baseline diet. Supplements you just have to add on top of your diet. Okay. Therapeutic diet can completely replace your normal diet, whatever you were consuming so far. Once you are on a therapeutic diet, it gets completely replaced by therapeutic diet. Okay. Nutritional supplements are not a substitute, they are not a replacement for your diet. These are the major differences. Okay. Is it clear to all? So, immunonutrition diets, there are specific micronutrients, macros, vitamins. Okay. They improve your immunity, they push your immunity to work better. Okay. So, diets that are supplemented with specific substrates like arginine. Arginine is an essential amino acid. Okay. Glutamine is an antioxidant. Omega-3 fatty acid, it's a lipid. Okay. Essential lipid. Okay, and essential fatty acid. Nucleotides, they are a part of your DNA, RNA. They are proteins that make up your DNA and RNA. Okay. So these are the main, like most well researched, medical evidence based nutrition. Okay, micronutrition that is supposed to aid your immunity. Okay. They also have a potential effect on your immunity or even your inflammatory post-operative responses. Okay. And any splenic perfusion and all, and if you have, they can help you with that as well. Okay. So primary endpoint reduction of post-operative morbidity rate. Okay. That can also be taken care of after operation. After operation, what kind of diet do you think is immediately prescribed? Like if you have at all, if anyone in your family has undergone an operation, okay, a major surgery, or you yourself have undergone a major surgery, or even if you're a woman, you have undergone C-section. What were the guidelines given to you to follow for the next 1 week, next few days? Yeah, initially it will be liquid diet. Okay, initially first few days it is liquid diet, then slowly semi-solid, semi-liquid. Okay, lots of liquids you have to take. Vitamin C you have to take. You will be put on juices. Okay, so very light food that is pretty easy to digest. Okay, that is the ones that is usually given. Yes, non-spicy. That ones that cannot irritate your gut. Okay, just a minute. Just a minute. Give me a 1 minute break. Okay, that is an emergency. Okay. So yeah, you all were right. The way how you have to get better soon after your surgery. Okay, light diet. Okay, you should have food that is not irritating your gut, like avoid spicy food, right? So these all are certain main aspects of gut nutrition, immunonutrition also. Okay, a lot of your immunity is dependent on your gut. Okay, if you have a weak gut, you don't have if you don't have essential microbiome in your gut, that would also lead to immunity related diseases. Okay, so arginine, when we talk about arginine, that is an essential amino acid. It usually maintains your body's pH level. It maintains a balance in your body. Okay. So that is the main function, especially when you are stressed out. There is a pH imbalance. So arginine, that is an essential amino acid that balances out the stress-related imbalance, controlling the pH level. Okay. It also makes sure that macrophages are the white blood cells that consume up all the foreign bodies in your body. So it also takes care that you have enough number of macrophages in your blood, neutrophils, that is leukocytes, your red white blood cells that are also increased. Okay, it is also a source of nitrogen because it is an amino acid. Okay, it's a protein. It's a part of your essential amino acid. So it also is a source of nitrogen. It enhances your wound healing, cellular immunity, especially if you are suffering from sepsis. Sepsis is a condition in which you are not afflicted by just one type of bacteria or virus. There is a colony of different types of bacteria that is attacking your system at the very same time. That is what we call as sepsis. Okay. Usually, when you undergo an infection, the causative agent is just one type of a bacteria or a virus. Okay. Here, the bacterial load, the species of bacteria is more than one. Okay. That is why we call it as sepsis. So, to overcome sepsis, also, arginine supplementation is important. Okay. It can also be used to reduce your BP. Then you have some purine nucleotides that are kind of an essential amino acid that takes care of your RNA and DNA based requirements. Okay, cell mediated immunity, immunosuppression. Your DNA and RNA is responsible for suppressing some cancerous growth and all. Okay, to promote that suppression, tumor suppression activity and all. Then glutamine. Glutamine is also an antioxidant. It's an amino acid, okay, but it is a very potent antioxidant. When your body is undergoing some severe stress, or if somebody is undergoing multiple organ failure because of any chronic diseases, okay. So in such cases, glutamine is prescribed. It's a really good antioxidant. It can take care of inflammation, okay, oxidative reactions within the body that is damaging your multiple types of tissues that can be taken care of by glutamine. Glutamine nowadays in the market, it is used for skin whitening, skin lightening therapies and all, because it can suppress the amount of melanin that is produced in your under your skin. Okay, that is the mechanism of action for glutamine. Surgical stress, critical illness, and even in cancer, some benefits has been shown based on the researches that we have so far. Glutamine has some benefits in all these areas. It can also reduce your hospital length of stay. Okay. The longer you stay in hospital, you are at a higher risk of developing new infections. Okay. So the hospital will also try to make sure your stay is short. Okay. Otherwise, it will affect their profit. Okay, short stay in the hospitals are profitable for the hospitals as well. Okay, not long stays. It is deleterious for the patient's health. It is also bad for the hospital's profitability. Okay, so that's about immunonutrition. Then you have the routine hospital diets. Okay, usually in hospital, these kind of diets are prescribed. Those who are not from a medical background, just for your knowledge. Okay, those who are in a clinical area of work, they would know this better. It is more important for them. Okay. So clear fluid diet, that is what you start with. Soon after the surgery and all, it starts with clear fluid diet, then full fluid diet, then soft solid or semi-solid. Okay. And then regular diet. So each one of this we will see in detail. Clear fluid diet, it can only provide you 300 kilocalories. There is not much protein here. Clear fluid diet, it is see-through, kind of see-through. Okay, it is made up of only with clear fluids. Okay, so that your body can easily absorb it, and but it will not give you much calories. Okay, so usually the food that stay in a liquid state, in a fluid state, even when they are in a room temperature, those food are usually prescribed here. Okay, and it should not have protein. Okay, because protein, your body requires time to break down protein when you eat protein. Okay, the body will take up, consume energy to break down protein. Okay, but when you are soon out of a surgery, or a patient is soon out of a surgery, we want to conserve the patient's energy, direct it towards wound healing, okay? Directed towards the other main areas of the body's function. We do not want to overwhelm the patient's body, okay, with energy consumed for digestion. Okay, digestion should be the last priority when you are recovering immediately after surgery. That's why no protein. Okay. It starts with clear broth. It could be non-vegetarian broth. For vegetarians, vegetable broth is available. Tea, black tea. Okay. Green tea, black tea, strained juices. Okay. Milk tea or milk coffee is avoided. It's not given. It has protein. So the conditions in which clear fluid diet are suggested, like acute infection, okay, acute inflammatory conditions, especially like IBS and all, okay, of the intestine. When you have you are just out of an operation, especially if any operation was done, surgery was done in your stomach, in your intestine, colon, rectal, okay, to make sure that the patient is not thirsty. Fluid diet can take care of the hydration as well. It can take care of the thirst as well. Okay. To supply the tissues with water, to make sure that flatulence happens. Okay. If somebody in your family has undergone a surgery, or you yourself, soon after the surgery, the doctors will ask, have you passed gas? Okay. So if you have passed gas, it means the gastric motility is all right. It's normal. Okay. And some people, they will require a push for flatulence to happen, gas to be passed after surgery. So putting them on clear fluid diet will take care of that. It will initiate the removal of gas from the intestine. Okay. Next, coming to full fluid diet, 1200 kilocalories and at least 35 gram of protein. That's more than enough in full fluid diet. Okay. So full fluid diet is frequently used as a middle step between solid food and a clear fluid liquid diet. All food that are liquid or are liquid at room temperature will also be used in full fluid diet. Okay. You can see it is providing much more calories than a clear liquid diet. Okay, clear liquid diet just 300 kilocalories. Here full fluid diet is given 1200 kilocalories, at least 4 times more the calories of clear fluid diet. So here slowly the calories are increasing. The intake of protein is also increasing. Okay. So when the patient is recovering, if you can notice positive recovery, that's when you're shifting the patient into full fluid diet. Okay. Nutritionally inadequate it is, okay, because you have to make sure the patient comes out of this as well. Okay. And it is only used for short periods of time. Okay. Otherwise, the patient may go into some form of deficiency. So that's full fluid diet. And it usually bridges the gap between clear fluid diet and soft food or semi-solid, semi-liquid food. Okay. So full fluid diet is that bridge. Okay. And usually in conditions like acute gastritis, acute infection, diarrhea, okay, in these conditions, full fluid diet is recommended. Milk is permitted here. So you can give them tea, coffee, which has milk, but not full tone milk, okay? Skimmed milk is recommended. And every 2 to 3 hours or 2 to 4 hours interval, you can feed the patient. If the patient is on nasogastric tube feeding, especially in that situation, okay, then you have soft diet, 1500 kilocalories, 35 to 40 gram of protein. Okay, so here it is also very similar to regular diet, but the food requires a little bit of chewing, swallowing. Okay, and then it is ready to be digested. But you have to avoid meat. Okay, any snacks that are crunchy, spicy food, um, very delicate and rich, creamy food like pastas and all, white sauce pastas and all, that has to be avoided. Fried food has to be avoided. Raw fruit, nuts, and veggies, steamed and smashed vegetables can be given. Okay, steamed and mashed carrots, steamed and mashed cauliflower, that can be given. But raw fruits and vegetables have to be avoided because that will increase the gastric motility. Okay, the fiber in raw fruit and vegetables, that will increase the motility and it will affect absorption. Okay, absorption will be slow and close to nil. Okay, nuts has to be avoided. It has much fat content. Okay, so too much of fatty food, uh, meat, especially red meat and all, completely avoided. And it is used following surgery of patients with infection, digestive disorders, chewing problems as well. Okay, those who have chewing swallowing problem, just now they must have done some jaw surgery. Okay, any tonsil removal and all is done. Okay, in such cases, soft diet is recommended. Then you have regular normal diet. Okay, which is easily digested. It's like a normal diet, easily digested, well balanced. Okay, maximum nourishment, minimum effort. That is the regular normal diet. Okay, and again, kilocalories, don't worry about it. Not everyone has to have 2000 kilocalories based on your personal requirements. Calories can be much less than 1800 as well. Okay, you can be on a regular normal diet. Patients can also be on a regular normal diet at 1200 or 1300 kilocalories. That is also normal diet. Okay, 42 to 45 grams of protein is recommended in a regular normal diet. And many special diets can also be included here, like if you have a keto diet or if you have a paleo diet, okay, oil-free diet, fat-free diet, low carb diet, these different modulations also can be uh, put on to regular normal diet. Okay. So this is the image of just 2000 kilocalories. It's too high for a person who is sedentary these days. Okay, 2000 kilocalories is also high calorie diet. You can do the portion control here. But the target is at least to achieve. See, there is no calories that are normal to adult man and woman. It depends on what kind of lifestyle you have. Okay, sedentary, moderately active, highly active. Okay, so based on that classification, the calorie intake varies. You can check the ICMR table. Okay, ICMR, the recent improvised table, you can just check that. It's mentioned there. Okay, so calorie intake should be directly proportional to your energy output. The more you work out, the more calories. Okay, and also your personal goals that you have. Do you want to be on a weight loss mode? Do you want to be on a weight gain mode? okay, based on your personal goals and your uh, energy output. Based on these two things, calories are usually determined. See, the time interval for each of these diet we have discussed so far, that depends on the recovery level of the patient. It's the doctor who will suggest when to stop having the clear fluid diet, when can you go to the semi-liquid diet, when the regular normal diet can be allowed. It completely depends on the doctor's recommendation. And the nurses and the nutritional clinical nutritionists, they have to just follow those orders. Okay. Protein diet of 35 to 40 gram is for all three meals. Generally, there is a lowest requirement. But based on the patient's body weight, height, and all, because protein you usually take based on your weight, 0.8 gram of protein per kg. Okay. So that your if your weight is above 60, above 70 and all, definitely a protein intake will be much more than 40 grams. Okay. So far, the different types of diet, is it clear to all? Next, we have the nutrition support service. Okay. Nutrition support service is generally the team of healthcare workers who are there to support you clinically as well as nutritionally. Okay, dietitian or clinical nutritionist is a part of this team. Okay, the team that consists of doctor, nurse, pharmacist, any other allied medical professionals like radiologist, physiotherapist, if at all the patient requires. Along with that, the dietitian also works in a very close contact with both of them. Okay, here you can see the dietitian is directly related to is directly interacting, having an interaction with the doctor, with the nurse, and also with the patient. Okay, so this is your nutritional support team. Patient is also part of your healthcare team. Patient is also a main functionary of your healthcare team. Okay, major health decisions. Should I go with this treatment? Should I not have this treatment? What kind of food I like? What are my dislikes? Okay, this the patient has to tell. Okay, and the patient's yes, no, likes, dislikes. Okay, is also put on the pedestal when you are making a care plan, nutritional care plan, or even health care plan. And other, this is the core team. This is the core team: patients, doctors, dietitian, nurse, pharmacist. This is the core team. Okay, then you have the sub team. Here, dietitians will also interact with clinical therapist. Okay, like physiotherapy and all, if at all required, not compulsory. Catering officer, you have to submit. For example, if the patient is going to be admitted, and if the patient is going to be here for the next 1 week, okay, you have to give the report to the catering officer that for this patient, please charge this patient for a low sodium diet. This is a hypertensive patient. Low sodium diet has to be given. Okay, avoid these vegetables, avoid these fruits. Okay, so you have to communicate that with the catering officer. Those who are planning to become clinical nutritionist, for them who have a medical background, for them. Okay, you have to have a regular, frequent communication with the catering officer as well. Okay, certain allergies and all that the patients may have, food sensitivities the patients may have. Okay, these things has to be communicated to the catering officer. For example, if the hospital is giving a salad, the hospital is going to put some avocados in the salad and the patient is allergic to avocados. Okay, so you have to give a heads up to the catering officer. Okay, so that kind of communication is required. And if the patient is found to be malnourished based on the nutritional assessments that you do, it has to be understood at admission. Okay, because malnourished patients will take much longer to heal and come back to health. Okay, their prognosis could be very slow. Okay, so if it is possible, if it is not an emergency situation, if it is possible, it's better to treat malnourishment first and then go with the clinical treatment. Okay, a well nourished body will heal quickly after being subjected to any clinical treatment. Okay, so is it clear to all regarding the nutritional support service? Am I audible now? Is my screen visible? So next is special feeding methods. Enteral nutrition, parenteral nutrition. What is the difference between these? So enteral nutrition means within or by the means of the gastrointestinal tract, which starts with your mouth, ends at your anus. Okay, so that is your gastrointestinal tract. So any food which enters either your mouth or even your direct stomach or directly just put into your intestine, all these are enteral nutrition. Okay, so usually we call it as tube feedings as well. To avoid confusion, enteral nutrition also means tube feeding. Okay, here your blood vessels are not at all used. Only your GI tract, your gastrointestinal tract is used. You when you take food orally, you normally how you eat food, okay, chewing the food, swallowing, that is also part of your enteral nutrition. Okay. Preferred route if you have adequate GI function. And when do you consider if a person has adequate GI function or not? If they are passing their excreta. Okay. If feces are there, they are okay with passing the feces. Okay. There is flatulence, gas is also being passed. Okay. When all these areas, if there is no obstruction, if there is no intestinal obstruction and all, in that case, we say there is adequate GI function. So go for a enteral tube feeding or any form of enteral tube feeding. Okay. But if there is any obstruction in the GI tract, okay, for example, removing a part of your intestine and all, so that surgery has been done. So in that case, we'll go for parenteral nutrition. So in parenteral nutrition, blood vessels are used, usually your veins. Okay. So people who do not have adequate GI function, for them, parenteral nutrition is chosen. Okay. So here you can see the difference between enteral and parenteral nutrition. Is an image clear to all? Things that are written on the image, is it clear to all? Is it visible to all? Okay. So you can see here enteral nutrition, any supplemental nutrition, if you take it through your mouth or even if it is given to you through any feeding tube, okay, that comes under enteral nutrition. Okay. So if you can see here the blue line, follow the blue line. Okay, through your nostrils, usually left nostril is used, right nostril is not used, left one is used. Most of us on the right nostril, you may have polyps, nasal polyps, that can cause some difficulty if you're inserting your nasogastric tube through your right nostril. It will cause some obstruction. Okay, so to avoid that, left nostril is usually preferred for tube feeding. Okay, so through the nose, the nasogastric tube will enter. Okay, and it stops at the, you can see, if you can see this blue line, there is a break. Okay, it stops at the fundus of your stomach, upper part of your stomach. Okay, usually the fundus of the stomach just has air. Okay, so that is nasogastric tube feeding. Then you have duodenum, nasoduodenal tube feeding. Again, the tube starts through your nose, but it ends at the duodenum. This C-shaped structure, that's C-shaped tube that you see, the stomach narrows down and forms a C-shaped structure. That is your duodenum. So from the nose, the tube is ending at your duodenum, at the mid part of your duodenum. This is nasoduodenal tube feeding. Usually it is used in cases where you do not want the food to get mixed with the hydrochloric acid in the stomach. Okay, you do not want the food to get mixed with the gastric juices. In that kind of conditions, a nasoduodenal tube feeding is given. Okay, or maybe somebody who has undergone gastric bypass surgery and all, so there is not enough space for the stomach to contract, churn the food. So in that case, nasoduodenal tube feeding is required. And the third one is nasojejunal. Through the nose, it goes till your jejunum. Jejunum is the mid part of your small intestine. Duodenum is the first part, jejunum the second part, ileum is the third part. Okay, through the ileum, your small intestine will go and join with the large intestine. Okay, so from the nose, the tube will go and end till the jejunum. Here, you do not want even the pancreatic juices to mix with the food that you are giving to the patient. Okay, so in that case, nasojejunal tube feeding is chosen. It depends on what condition the patient is going through. Okay, does the patient has pancreas? Does the patient has liver? Okay, is it functioning properly? Does the patient has a complete stomach? Okay, considering all these cases, the doctors will prescribe what kind of tube feeding is recommended here. Okay. Then comes second type of tube feeding, which is otomy based. Otomy means what? Whenever if a medical terminology ends with otomy, okay, OTO, or sorry, ostomy, STOMY. Okay, so that is, you are putting a hole in the body. Okay, and through that hole, the tube will, any form of tube will enter into the body. Okay, like for example, tracheostomy, a hole is created in the throat, in your trachea, so that the person will be able to breathe properly. Ventilation can be put on. Okay. Okay, so that is gastrostomy. Here you are making an opening through your, just under the rib cage. Okay, an opening will be done, and the tube has to enter the midsection of your stomach, not the fundus. Okay, the midsection of the stomach, and then you have the antrum of the stomach, that is the end part of the stomach. Okay, so through gastrostomy, you are making a tube to enter into the stomach. Okay, so an artificial external opening is created. Surgically, it is created, and you have to really take good care of this opening. Okay, there are high chances that infection can take place if you are not maintaining the hygiene, and if you are not maintaining the aseptic methods of cleaning this ostomy. Okay. See, the size of the tube matters here. If for children, there is a different size of the Rice tube. That's the name of the tube for nasogastric tube feeding and all. Okay. With age, different sizes are available. Okay. So usually it will not get stuck. Yeah, stoma bag is also stoma bag is usually used for patients who have colon cancer, and the stoma bag is used to collect the feces. Okay, excreta. Next kind of ostomy that is done is in your jejunum, the mid part of your intestine. Okay, below your spleen, an opening will be done, and a tube is inserted that ends at the jejunum. Okay, again, you have to be very careful with the aseptic methods of cleaning the ostomy. Okay, prevent infection. It has to be well dressed. Dressing has to be proper. So again, the type of food that is given in gastrostomy, jejunostomy, it is not normal food. It is partially hydrolyzed food and all. Okay, formula feeds are given here. Okay. Then when you come to your enteral nutrition, you have two types of enteral nutrition through your central vein, that is the central line will be put, okay, through central vein, and then through your IV. When you get admitted in hospital, usually when they say you are put on glucose, okay, we have to put glucose, we have to put NS, DNS, okay. So those things, how it enters your body, it is through your veins, peripheral veins on your hands, okay, back of your hands, sometimes through legs. If you don't find good veins in your adequate veins in your hands and all, sometimes legs are used. Okay, your forearm and all is used for IV, for the IV to enter the body. Okay, so that is peripheral veins. Central vein, you are directly pushing the feeding into the major vein vessels of your body. Superior vena cava. Usually, superior vena cava is used. So is the difference clear to all between parenteral nutrition and enteral nutrition? So next is type of okay, what kind of food we usually choose in these kind of tube feedings. Okay. So first is your natural liquid food. Like if you're giving milk, skimmed milk is chosen usually. Okay, we don't go with full tone milk because the fat present in the full tone milk that can obstruct. Okay, that can solidify and obstruct the tube, if at all. To prevent that, skimmed milk is used. It is much easily digestible as compared to full tone milk. Okay, uh, eggs that are either the egg white or the complete egg which is mixed properly. Okay, that can be given. When you cook rice, okay, you take the starch, filter out the starch water. That starch water, cereal water can be given, or even if you're boiling dal, okay, and just strain out the dal and whatever water remains, that can also be given. So that is the cooked strained cereals water, okay. Sugar or any form of molasses like honey, maple syrup, okay, these can also be given. Vegetable oil can be added into the mix, whatever you prepare. But why vegetable oil? It stays in the liquid form, even in room temperature. Okay. Animal-based coconut oil and all and ghee, okay, that will solidify in room temp. It can sort of solidify in room temperature. Okay, so go for vegetable oil if you want to meet the nutritional requirement of the patients. And if you have to add some fat, always choose vegetable oils, okay, that stay liquid in room temperature. Non-fat milk is used. Dry milk or milk powder can be used, which is not full tone. Okay. Green tea, black coffee. Okay, these can also be given. Those are naturally liquid food. Strained juices can be given. Then we have blenderized feeding. Blenderized feeding, we go for when you have degenostomy, gastrostomy. Okay, in these kind of situations, blenderized feeding is given. First, the food will be cooked, okay, like steamed carrots, steamed vegetables, okay, but you will cook it properly. You will add adequate water into it, blend it, okay, and then it blend it into such a thin paste that it can easily pass through the nasogastric tube film. Okay, remember the in the piston you have a syringe, okay, needle, and then the piston. Okay, uh, so it should come easily into the piston part of the syringe. Okay, and then through the piston method, the piston will be pushed through the syringe. The food, the blenderized food feed has to go into the NG tube. Okay, so it has to be that thin. So you have to make sure what should be the consistency. The consistency should be fine enough, thin enough, okay, that it can go into the syringe and it can be pushed into the nasogastric tube. That is blenderized feeding, and usually 1.5 liter of water is used to make this feed. Okay, and it should give 1,500 kilocalories as well. So one day, if you're preparing the blenderized feeding, 500, 500, 500, 500 ml in the morning, 500 ml in the afternoon, 500 ml for the dinner. Okay, like that, you have to cook vegetables and blend it with water properly. Blend it. If straining is required, strain it. If you see that you have not blended it properly, then go for straining, and then 500 ml each meal a day is given. And it gives around 50 grams of protein. So you can add eggs as well. And it will not cost more. Whatever vegetables that are seasonally available, you can boil or steam. Okay, whatever vegetables you can boil or steam, or if it is seasonally available, that is used. Cook it, steam it, or boil it, blend it properly. But blending is the main aspect here. It has to be really fine. It should not be coarse. You can add prebiotics and probiotics into it. Even the tablets, prebiotic, probiotic tablets that are prescribed, lactobacillus tablets that are prescribed, that can also be blended into the feed. Okay, then it can be given. You can use milk, starch, milk powder, egg, soya flour, refined oil, salt, curd. These things can be used. Elemental diets. Elemental diets, for example, if I say Herbalife, Nutri-Life, you understand what these brands represent. Muscle Blaze. Are you getting an idea what could be elemental diets? So these are kind of a meal replacement or food replacement. Okay. Yeah, meal substitutes or food substitutes. Usually Herbalife and Nutri-Life and all, they follow the meal substitute techniques. If you want to lose weight, don't have breakfast, but consume this one packet of some strawberry flavored, chocolate flavored, okay, something like that. Uh, Powder is available, either in mix it with milk or water, blend it and have that shake. That is your breakfast, nothing else. Okay, so these are elemental diets. Okay, normal food is replaced by elemental diets. Usually, it can be beneficial during the clinical nutritional stages. Okay, long-term effects of it, we still don't know. Okay, there are very few cases who may be on elemental diets for the past 10 years or 20 years. We do not know what would be the long-term effects of any elemental diets on your internal health. Okay. They contain a lot of amino acids that they can take care of your essential amino acid requirement, essential fatty acid requirement. Okay, they can control your fat intake as well because they come with good fats. All the micronutrient deficiencies can be cured, but still uh, the palatability of the food, okay, the aspect of your stomach actively digesting food, breaking down food, okay, the aspect of your intestines absorbing food from natural food, those areas may get affected. Okay, so long term use of elemental diet, we still do not suggest it. For a short term, if you want to achieve a short term goal, if you want to correct some nutritional goal, okay, protein powders are also a part of elemental diet. Then types of feeding. This is like feeding cycle. Okay, at what time period you have to give food. So this gray part that you see, whenever you in all these four clocks, if you see the gray part, that is the part when feeding has to be done. Okay. Continuous feeding. Uh, have you heard about infusion pump, injection pump, infusion pump in ICUs? In ICUs, we use infusion pump, injection pump. Okay, they are the example of continuous feed. Okay, what happens is that the regular IV, you go to a hospital, you get admitted, they put you on glucose, NS, and all. Okay, that is controlled by a handheld, a small controller is there, IV controller. Okay, uh, it's not that precise, but when you use an infusion pump, that tube goes through a mechanical system in which you can set the time. Okay, and within that time, the infusion pump will make sure continuously the medicine is flowing at a controlled, it at a very controlled pace. Okay, injection pump also, if you don't want to give 500, 700 ml of feed, okay, just 100 ml of feed or 50 ml of feed has to be given. That will be put under injection pump. Okay. If too much, the volume is too much, infusion pump will be used. If the volume is less, injection pump will be used. The normal injection, you know, if it is a 10 ml syringe, 50 ml syringe, you know how big it is and how you quickly give an injection. Okay, but the same amount if you want to give at a 6-hour pace, drop by drop, it is impossible for a nurse to stand with an injection, 50 ml injection for 6 hours and give one drop at a time to the patient. It's not possible. So that's why injection pumps are used. So they come under continuous feeding. Okay, 24 hours a day, 6 hours a day, 12 hours a day, depending on what the doctor has recommended, these pumps are used, and it is only used for enteral nutrition. Okay, you cannot put a nasogastric tube through injection pump or infusion pump. Okay, then you have cyclical tube feeding. So again, enteral nutrition, okay. But if it is less than 24 hours a day, you just have to give for this particular glucose or this particular multivitamin mix, okay, for just 12 hours or 6 hours, less than 24 hours. If you want to give this, put the patient on an infusion, then cyclical movement is used. Okay. It is on, it has an on and off period. Continuous, in continuous, you can see there is no break at all. No break at all. Okay. But in cyclical, you can see there are on and off periods. 8 hours, 16 hours off. Okay, at night, you don't want the patient to be on feeding. Only till morning 6 to evening 6, let the patient be on a feed. Then you can remove it, let the patient rest, move around. Okay, so in that cyclical method is used. Then you have intermittent method or interrupted method. Both are the same name. Okay, from the name itself, we can understand there is an interruption. Okay, for at least half an hour or 60 minutes, half an hour to 1 hour, you will give the enteral nutrition. Okay, then 2.5 or 3 hours break. Again, half an hour or 1 hour nutrition. Then 2.5 hours break. Like this, every 4 hours, 6 hours. Okay, taking a break of 2 hours or 3 hours, whatever is recommended, and giving medication or giving the food only between that 1 hour continuously. Okay, within that 1 hour, 30 minutes, whatever time it takes. That is intermittent feed. Mostly it is like 4 hours off, 4 hours on. Okay. Then you have the bolus method. Bolus means a big dose. Bolus is a big dose. Large volume is given in a very short time. Okay, maybe 200 ml. 200 ml within 10 minutes is given. And then after 2 hours, again 200 ml within 10 minutes is given. Usually nasogastric tube can be used here as well. Okay. So all these different types of feeding requirements, is it clear to all? At what intervals and what are the names of it? Is it clear to all? Once you read it again, you will register it better. Okay. Then we have total parenteral nutrition, TPN. Okay, PPN means peripheral parenteral nutrition. TPN is total parenteral nutrition. Both are enteral nutrition. As I mentioned earlier, when you use your veins, normal veins on your hands and all, like how you are put on a glucose, okay, intravenously. Okay, that is PPN. But when central line is used for your nutrition, that is what we call as TPN. Okay. So in total parenteral nutrition, all the nutrition, all the essential nutrition together is supplied through your IV, your veins. Okay. Um, at least 150% hyperalimentation is required in that case, and also to make sure there is a positive nitrogen balance. How do you get positive nitrogen balance? When you have more amino acids than what you lose. Okay, the nitrogen that you lose is less and the nitrogen that you gain is more. Okay, that is positive nitrogen balance. For weight gain, usually for weight gain, patients who are chronically ill, who are in hospitals for a very long time, they will be put on TPN. Okay, so that they don't lose weight while they are on these kind of nutrition. Okay, usually when majority of the nutrients has to come through an enteral source. Okay, peripheral veins are too tiny as compared to your superior vena cava, the major veins. Okay, and what is the major difference here is when you put some fluid into the veins of your hands, you can visualize, if you can see the veins at your hands, you can see how thin they are. Okay, they have a limited space where the fluid that you're injecting it has to get mixed with the blood volume. Okay. With peripheral nutrition, that mixing will take time. But if you're going for TPN, the diameter, the circumference, okay, of the superior vena cava is much larger as compared to your normal peripheral veins. So immediately, whatever nutrition you will give, immediately it will get mixed with the blood volume and the heart will pump it directly to all parts of your body at the same time. Okay, because through the superior vena cava, it is entering into your right atrium. From there, it will go into the right ventricle. Okay, from there, it will go into the pulmonary veins and all, and it will pulmonary arteries and all, and then it will gas exchange will take place. It will reach all the parts of your body. Okay, so that is the idea behind TPN. Just to make sure that immediately whatever nutrition you are passing, it immediately gets mixed up with a huge blood volume that is present in superior vena cava, which is not that present in the peripheral veins. Is it clear to all? TPN, through TPN, 150% more than what is required. 150% of your nutritional requirements can be met. Peripheral nutrition, the normal IV lines that you are put on, that can meet up to 30 to 50% of your daily requirements. But TPN can take care of more than your daily requirements. Usually, malnourished children, malnourished individuals will be put on TPN for faster recovery. Okay. And in your textbook, lot many tables are given regarding the TPN for children. Okay. Uh, Protein requirements and all, it is given. No need to read that. That is for clinical practice. Those who have a clinical background, they can study those tables at your own time. You can do a self-study because you're already trained in these areas. Okay. So it will just be a revival of topics for you. Okay. So just read it at your own time, at your own convenience. Questions from this will not be asked. Okay. Because this is the clinical part of the nutrition. Not for those who are from the non-medical background. So TPN is also called as central parenteral nutrition, CPN, okay, or alimentation, because it will get mixed up easily with a large blood volume. Okay. Because nutrients are supplied in excess of needs. You require 100%, but TPN is giving you 150%. More than what you require, your TPN is going to give you. That is why it is called hyperalimentation or hyper. Large amounts of nutrients in a hypertonic solution can be supplied via TPN. The catheter is surgically placed into the superior vena cava. Surgically, it's not a big surgery or something. Okay. In the ward itself, central line insertion can be done. Okay. And it is directly put into your superior vena cava. That is a main large vessel of your heart. Okay. Like aorta leads to all your arteries. Superior vena cava brings all your veins together into one big vein. Okay. And usually the superior vena cava, you have two vena cavas. Superior vena cava, inferior vena cava in your heart. Superior vena cava, the veins that supply to your upper body, above the shoulder. Okay, even your chest, lungs as well. Okay, those come and join into the superior vena cava. Inferior vena cava will bring all the veins from below the body, below the heart. Okay. The reason that larger amount of nutrients, because TPN, big dose of nutrients you're going to give the patient, okay, which is in a hypertonic solution. It's not isotonic, it's not hypotonic. Hypertonic means concentrated, okay, concentrated. It has to immediately get mixed with large blood volume. Otherwise, the cells nearby will try to absorb it to bring the equilibrium. Okay, wherever you're placing the hypertonic solution, that cells will try their best and overwork to get the pH balance. Okay, so that's the reason why big, large blood vessel is used. So hypertonic solution can be supplied through superior vena cava. Then with peripheral parenteral nutrition, that is superior vena cava has a much larger diameter and it also has a higher blood flow rate. Okay. Why not inferior vena cava? Because gravity is working against inferior vena cava. When you are selecting superior vena cava, you can see here in the previous image, this is your superior vena cava. Okay. So imagine a fluid that is coming into this. By gravity, immediately it will go down, get mixed up, and be utilized completely. Inferior vena cava is somewhere down here. Okay, to pump the parenteral nutrition into the inferior vena cava, it's like you're working against gravity. Okay, so is it clear? Is the idea behind TPN, is it clear to all? So complication with TPN, infection is the most common complication. Again, wherever there is a central line, there is always going to be a risk of hospital or healthcare acquired infection. So infection is going to be the most common complication. Okay. Whenever a patient is put on central line is the needle that you surgically place into the vena cavas. Okay. So you are putting in a device, a medical device into a human body and you want it to stay in place. It's an external thing that you are putting into a human body. You want it to stay in place free of infection. It's difficult when the patient moves around, takes a bath and all. Okay, and the patient is always in the hospital environment surrounded by various infections. There are high chances new infections may get transmitted. Okay, air embolism may take place if you are not placing the tubings properly. Air can escape into the tube. It can go into the vessels. It will go into the heart and it can block your lungs, cause breathlessness, and it can cause immediate death. Air embolism can cause immediate death. Okay, it can also cause paralysis if it gets stuck in any veins or arteries or blood vessels of your brain. It can cause paralysis as well. So that is complication. Then hyperglycemia, because high amount of nutrients, 150% of carbohydrates, if immediately it is getting into your body, okay, in one shot, obviously there are a risk of high blood sugar levels. Then you have hypoglycemia. Okay, hypoglycemia, again, if you have if the blood is not getting mixed properly with the solution that you have inserted, okay, the patient may go into a case of hypoglycemia. Electrolyte imbalance, because it is a hypertonic solution, high concentrated solution. So whatever balance you already had in the body, when you give this shot of hypertonic solution, highly concentrated solution, it can cause some imbalance in your electrolyte levels. Fluid imbalance, fluid disturbance. If electrolyte imbalance is there, fluid imbalance will also be there. Okay, either you will have a swollen body or you will have you will undergo diarrhea, too much of urination. Okay, you will lose a lot of water weight from your body acid-based disturbance, pH disturbance. Okay, and usually at an electrolyte level, all these imbalances will cause uh, these situations. So these are the complications of TPN. Then we have the refeeding syndrome. Is the words clear to all? So refeeding is a complication of enteral feeding or parenteral feeding. Okay. Usually when you are giving these different feeding techniques for a malnourished patient, okay, there are high chances that uh, too much of anabolism can take place. Okay. That is from when the patient is malnourished, they are in the state of catabolism. Each and every macronutrient they have in their body came from breaking down their own body. Okay, if it is protein, it came from breaking down their muscles. If it is fat, it came from breaking down their adipose cells. Okay, if it is glucose, it came down breaking their glycogen stores in the liver and muscles. Okay, so a person is in a state of catabolism. Catabolism means breakdown. Okay, breaking down their own body stores for survival, nutritional body stores for survival. So when a person is in catabolism and immediately you admit them and give all these feeding, okay, TPN, PPN, and whatnot, or you're putting the patient through all these feed, suddenly the body goes into a state of shock. Okay. Till now, there was nothing, and now more than what is required is present. It, it will obviously create a disbalance, right? So that is refeeding syndrome. Okay. When you are trying to refeed the patient, multiple organ failure may take place. When you are trying to refeed the patient into health, it will not always give a positive effect. Multiple organs at multiple levels may undergo disintegration. Their functions may undergo disintegration. That is refeeding syndrome. Okay. So when the body was in a state of catabolism, now there is an immediate rapid shift and you're pushing anabolism. Okay, so that is a shift back of carbohydrate metabolism and protein synthesis. Now immediately the body has to stop breaking down glycogen. The body has to stop breaking down uh, the muscle protein, because now they have more than enough of carbohydrates and proteins. Okay, now the body has to rapidly shift into anabolism. It will cause some systemic level failures. It may cause, okay, not always, it will not happen always, but it has the potential to cause a different systemic level failures. Okay, and these failures, it could be neurologic, cardiac, pulmonary, renal, hematologic, means your brain is affected, CNS system is affected, your heart is affected, your lungs is affected, your kidneys are affected, your blood is affected. Okay. What actual effects happen is written down here. We can just go through it. So just imagine your central nervous system goes into a shock. That what happens? So far we didn't had anything. Now we have more than everything. System goes under the shock. The patient may become confused. The patient may have fits, seizures. The patient may also go into a state of coma. Okay, because suddenly the electrolytes have got disbalanced. Okay, cardiac, the patient may undergo cardiac arrest. Okay, cardiac overload, cardiac arrhythmias can also take place. Pulmonary, respiratory problems may start happening because suddenly there is a rush of electrolytes into the blood circulation that can cause breathlessness. Okay, renal, kidneys were working on bare minimum. Kidneys were working on really bare minimum. Either it could be water or nutrients, electrolytes, whatever. Kidneys were working in bare minimum. Now they are within a day or within few hours, the kidneys are overloaded, overworked. Okay. They may not be ready to catch up to the overload. That could lead to renal failure. Okay. It may also cause cellular edema, body edema. Okay. Then hematological hemolysis can happen, rapid breakdown of red blood cells. Platelets may not function properly. Okay, so these are the situations that can arise because of refeeding syndrome. Is it clear to all? See, uh, it can be started at a low level if the patient is not at a serious condition of malnourishment. Okay, so we we can just do the nutritional assessment and blood studies and all to understand what is the seriousness. Okay, and whatever you prescribe, it always have a 2 to 5% chances that this treatment can derail the patient's health further. There is always that chance with any operations, minor or major, you take. There is always a 2 to 5% chance that it can derail. Okay, so refeeding syndrome is also, it will also come under that derailment. Okay, so nutritional and wound healing, protein requirements will be increased when you are undergoing wound healing. Wound, see, surgical wounds are also a type of wound. Okay, surgical incisions, stitches, they are also a wound. Okay, and if you undergo any road traffic accident, that is another type of wound. So protein 1.5 gram per kg protein is required. If you have an ideal body weight and you are undergoing wound healing, okay, 1.5 gram per kg is required. Otherwise, if you have a sedentary lifestyle, 0.8 gram per kg is enough. But if you're undergoing some form of wound healing, okay, your protein intake has to be slightly higher. Okay, then energy requirement 30 to 35 kilocalories per kg. That is fine. Okay, both from fat and carbohydrates. Fluid intake should be adequate, 30 to 35 ml per kg. This completely is based on your patient's or your body weight. Okay. Micronutrients, you don't have to increase the supplement of micronutrients apart from vitamin C. Okay. Apart from vitamin C is required. It aids in wound healing. Okay. Glutamine can also be prescribed. Omega-3 fatty acids, vitamin A. Vitamin A, if deficiency is not there, that is enough. You don't have to give extra supply. Okay, but vitamin C, it is essential. Okay, focus on vitamin C from vitamins. Minerals, you don't have to worry much about minerals for wound healing. The normal, if the patient is not deficient, continue the same diet. So pre and post operative nutrition and intraoperative nutrition before your surgery. Pre-operative means before surgery. If you have any surgery, okay, how do you prepare the patient? Make sure the patient is not dehydrated. The patient's body is well hydrated before surgery begins. Okay, avoid excessive fastings. Just 12 hours of fasting is more than enough. Nil per oral is prescribed. Okay, if tomorrow at 9 a.m. is your surgery, today from 7 p.m. onwards or 8 p.m. onwards, nothing, no food through mouth is allowed. Okay, fluid you can take. They can drink water at least 2 hours before surgery. Okay, and if any further requirements is there through fistulas and all, or stomas and all, that is clinical part. Okay, through that you can maintain it. When the patient is in intraoperative state, that is in the surgery, when the patient is inside the surgery, okay, maintain fluid balance. uh, NS, DNS, okay, IV fluid are kept ongoing. When you are under anesthesia, when you are under the surgery, these fluids are ongoing. Okay, so avoid excessive fluid therapy. Okay, Hartmann's formula is used. That is for the doctors, not for anyone else. That formula is used to maintain the fluid balance during surgery. Blood transfusion, as indicated before the surgery begins, blood bags and blood banks are informed. Okay, we require at least these much bags or bottles of blood. Okay, they are kept ready. That's how you maintain the fluid during surgery. After surgery, when the patient is admitted in the post-op ward, um, as soon as possible, you have to encourage oral feed intake. Okay, so that the gastric motility kick starts off, and it is rising out of anesthesia. Okay. Stop the IV fluids once the oral intake is established. Okay, so that you focus more, you encourage the patients to take more food through mouth and not be dependent on IV fluids or parenteral nutrition, enteral nutrition and all. Okay. Your aim should be for state 0 fluid balance. That is no IV fluids at all. That is the aim. If the oral intake is delayed, that's when you will go for enteral nutrition or parenteral nutrition as per doctor's recommendation. Nutritional supports for burns, when there is a burns injury case. Okay. There is a lot of stress response. It also depends upon the degree of burn. Okay, there are different degree, class 1, class 2, class 3. There are different degrees of burn. Superficial burns, only the epidermis is affected. Okay, second degree burns, your subcutaneous fat level is affected. Third degree burns, your muscles are affected. Fourth degree burns, till your bones it is affected. Okay, so there are different degrees of burns. Okay, so wound healing is required. Immediate stress response is given. Emergency action is taken. Maintaining the fluid and the nutritional requirement is important, because when the body is burnt, any part from that area, that burnt area, continuous water loss will be there. Okay, you have exposed the cells and tissues to atmosphere. Direct water loss will be there. So maintaining hydration is very important. Okay. It is due to rapid water loss and rapid nitrogen loss from the burnt area. That's what leads to death due to burns. Okay. Goal is to promote the state of nitrogen balance. As I mentioned, wherever you have a wound, even if it is not a burn, it's a normal wound, always remember fluid and nitrogen is being lost through that. Okay. So the goal of the nutritional support is to make sure nitrogen balance is required. So what kind of diet you will focus here? What is the major macronutrient you have to focus? When I say nitrogen balance, what is the major macronutrient that should come into your mind? Yes, it is proteins, amino acids. Okay, they are the only macros that have nitrogen. And the loss of protein depends upon the extent of the burn. More you have a burnt area, surface area, more protein you have lost. That has to be replaced. So nitrogen has to be replaced. Fluid and electrolytes has to be replaced, because through exudate pus formation, okay, fluid and electrolytes are going out. That has to be replaced. Blood loss, because of burns, blood loss may happen. That could lead to anemia. So iron has to be brought in. Okay. So whatever protein you give to the patient in the first 1 week, they are not able to retain it. Okay, it has to be really high dose of protein. And their basal metabolic rate is also quite high because the body is in a state of catabolism. Body, when you undergo burns, body is in a state of how will I break down all the body parts to for survival. That is the mode that your body will go into catabolism, severe catabolism. So in the first 1 week, whatever nutrition you have given, hardly the patient will be able to retain it. Okay. And the nutritional support is completely based on the percent of total body surface area burnt. TBSA means total body surface area burnt. There are different, the palm technique, there are different formulas, okay, that doctors use to understand how much body surface area is burnt. Okay. So nutritional recommendations will come from the doctors based on how much total body surface area has undergone burns. Feeding will begin immediately or at least 24 hours to 32 hours post burns injury. Usually enteral route is preferred. Jejunal feedings are most usually followed here to maintain nutritional status. And you do not, even if you put something directly into the stomach through nasogastric tube feeding, there are chances of aspiration. Aspiration means if the patient is coughing, sneezing, that content that is in the stomach can regurgitate back and go into the trachea. Okay. So to avoid that, directly you will make an ostomy and give jejunal feedings. Okay. So no way the food will regurgitate back into the trachea. So that's about therapeutic diets. If you have any queries, you can mention in the chat.